Hi, this is Dr. Muad Faleh from Saudi Arabia, Dammam. I have my paper is about assessing quality of life for pediatric tracheostomy patients and their caregivers. It's a cross-sectional study using the pediatric tracheostomy health status instrument. So there is nothing to disclose and there is no conflict of interest or any financial support. As we all know, pediatric population undergo tracheostomy for a variety of reasons, and for the child and their family, having tracheostomy means learning a new way of life, facing several social, psychological, and medical challenges. So our aim was to assess quality of life in regard of these four domains: physical symptoms, in regard of how much support he needs at home, from suctioning to respiratory support, a medical visit, how many times they go to ER or to an ENT doctor, stress and coping of the child. From a family perspective, how do they see this tracheostomy changed or affected his life? Stress and coping from a family perspective, how it affected their quality of life, their work, their social life, and so on. So our study aimed to highlight that we are in need to establish a better home care training program to support all victimized children and their families. It's a descriptive cross-section study out of 56 children undergone tracheostomy, 24 included in our study. They were following up with us between September 2017 and May 2022. Clinical data collected from medical records and using the PTHSI tool. So demographic data, as I said, collected from clinical records, and we used the pediatric tracheostomy health status instrument, which is a validated instrument as a quality of life questionnaire. It had four domains, as I explained before. It has score from 0 to 150. The higher score they get, it indicates a higher overall quality of life. It was translated to Arabic language with forward and backward translation and check, and phone interviews done with caregivers. All data were fed and analyzed using the SPSS software. Our inclusion criteria was any patient younger than 14 years or currently on tracheostomy, and exclusion criteria was a patient who lost follow-up, weaned of tracheostomy, above 14 years old, or passed away. So results from the 56 patients, a total of 24 were recruited. 15 were males and 9 were females. The mean age in months was 79 months. And major medical conditions were counted in as cardiac, neurological, pulmonary, and so on. And for the age group, most of our patients, more than 50%, were less than 2 years, and the rest were from 2 years to 14 years old. Major medical conditions, 75% of them had major medical condition. As I said, either cardiological, neurological, or pulmonary issues. So the questionnaire itself had 7 items for physical symptoms, 6 for medical visit, 3 for quality of life of the child, and 17 regarding the stress and coping mechanism for the family. And higher score indicates good health, and lower score indicates poor health. And the overall mean score for our questionnaire was 93.3 out of 150, which is 62%, indicate a good quality of life. We compared it to other studies, which did not compare favorably to a study done in Boston Children's Hospital and Cape Town Red Cross War Memorial Children's Hospital using the same tool. The children in our hospital report less favorable quality of life scores regarding frequency of physical symptoms. We scored 19.8 compared to 20.6 in Boston and 24.8 in Cape Town. Quality of life of caregiver was 41 compared to 48.9 in Boston and 62.3 in Cape Town. And quality of life of the child was the worst with 3.5 in our group when compared to 8.7 in Boston and 8.8 in Cape Town. So our overall mean score was 93.3, which compares also less favorable to the overall score of Cape Town Red Cross War Memorial Children's Hospital, which is 110. Major medical comorbidities in children resulted in significantly lower overall score compared to other patients with no major medical conditions. But it's clear that this subset of patients and their family will need more specialized care. So our conclusion that this study highlights the stress that these families can experience when caring for these patients, and they need to have a good training in hospital before discharge, and this will help them to have better quality of life and decrease the stress they face each day with the tracheotomized patient. So using our data, we showed that we have a lower quality of life compared to other studies. And as I said, we need to establish in the future a home care training program to support all children and their hospital. And we are currently conducting a multi-center survey in the eastern province of Saudi Arabia. That's it.
Yes, of course. Good afternoon, dear colleague. My name is Anastasia Nedeyka. I'm a graduate student and an otolaryngologist. I'm from Belarus. I bring you attention the presentation of our report. The primacy of medicinal treatment for chronic rhinosinusitis with nasal polyps, the minimal invasiveness of surgical invitation, and the combination with perioperative drug preparation are common position worldwide. One of the most common approaches in the treatment of chronic rhinosinusitis with nasal polyps is a functional endoscopic rhinosinus surgery using intranasal glucocorticosteroids. The efficacy of drug therapy is as high as 50%. Possible complications of surgical treatment and the recurrent nature of the disease require the search for new therapies for chronic rhinosinusitis with nasal polyps. Currently, a promising direction is the use of cellular technologies for the treatment of various diseases. Mesenchymal stem cells are one of the successful biomedical cell products. From cell therapy, views pathogenesis of chronic rhinosinusitis with nasal polyps is based on abnormal remodeling response and immunoregulatory disbalance with a decrease in regulatory T lymphocytes and a disruption of their migration potential. Mesenchymal stem cells of olfactory line have multiple differentiation potential, have low immunogenicity, don't have an increased risk of malignant cell transformation, have immunomodulatory function due to migration and implantation in the inflammatory mucosa of nose, restoring the immune balance of T helper 1, T helper 2, and activated regular cells. They are able to stimulate tissue regeneration. Mesenchymal stem cells can eliminate inflammation, weaken the imbalanced response of T helpers, and improve healing process by increasing quantity and quality of the cellular matrix. Mesenchymal stem cells exert their influence through intercellular complex and the release of soluble factors. The objective of the study is to assess the effectiveness of biomedical cell products based on mesenchymal stem cells olfactory line in the treatment of patients with chronic rhinosinusitis with nasal polyps. The main group 1, number 14, includes patients who underwent cell therapy after surgery. The main group 2 includes certain patients who had cell therapy on the day of the operation. The control group includes patients who haven't undergone cellular therapy. You could read exclusion criteria on this slide. Inclusion criteria are right and informed consent, females and males age from 18 to 85 years, code of disease in international classification disease number 10, G33.0.1.10.9. All patients underwent the algorithm of diagnostic procedures upon admission to the hospital before surgery and up to 6 months after surgery. Analysis of patient complaints, surgical history, endoscopic examination of the nasal cavity, and rhinocytogram. Surgical treatment included surgery on the paranasal sinus and the nasal cavity. Histological assessment of the nasal mucosa was performed on 8 patients of the main group and 6 patients on the control group up to 3 months after cell therapy and after surgery in the control group. All patients used intranasal glucocorticosteroids for 2 months after surgery, a dose of 400 micrograms per day. There is no statistically significant difference between the group by gender and age. The groups are comparable. There is no statistically significant difference between the groups by duration of the disease. The groups are comparable. The duration of the disease is about 13 years in group where patient gets cell therapy after operation. The duration of the disease is about 9 years in group where patient gets cell therapy in operation and in control group. Almost all the patients underwent endoscopic polysinusotomy according to medical indications. Septoplasty and turbinoplasty were performed. The injection was performed under local topical anesthesia or general anesthesia. The injection volume was 1 milliliter, 10-15 million cells. The mesenchymal stem cells was introduced as submucous injection of the nasal cavity, which was practically unchanged by the pathological. Mesenchymal stem cells underwent quality control before its introduction. Morphological parameters, immunophenotypic parameters, immunosuppression expression parameters were assessed. H culture underwent sterility control. 71% of patients in group where patient got cell therapy after operation get out transplantation. All patients in group where patient got cell therapy in operation get allotransplantation. The most common complaints in patients of all group at initial treatment were difficulty in nasal breathing from 86 to 100%, colored nasal discharge from 42 to 62%, anosmia about 50% in all groups. We obtained statistically significant difference in the groups up to 6 months after surgery for difficulty in nasal breathing. In group where cell therapy was carried out along with the operation, difficulty in nasal breathing didn't occur. In the control group, it was 33%. According to colored nasal discharge, in the group where cell therapy was carried out along with surgery, 50% had colored nasal discharge, and in the control group, it was 57%. Hyposmia occurred in the 57% of patients in the control group compared to 50% in the main groups. Using cell therapy in addition to standard treatment of chronic rhinosinusitis with nasal polyps for up to 6 months, statistically nasal breathing reduces the sense of smell. We obtained statistically significant difference between the main groups compared with the control group during endoscopy of the nasal cavity in the number of polyps, nasal discharge, and the edema, according to the Land-Kennedy scale. You can see endoscopic conditional of the nasal cavity in patient after surgery and cell therapy at different stage. Using cell therapy, statistically significantly improves the condition of nasal cavity according to endoscopy. We obtained statistically significant difference in the group where cell therapy was carried out along with the operation compared with the control group during the nasal cavity on day 6-7 after surgery, against the background of nasal irritation with physiological solution 2 days after surgery. In the main group, there were significantly fewer crust and discharge. Using cell therapy improves the course of the early postoperative period. We obtain statistically significant difference in the average value of the specific gravity of neutrophils in nasal discharge according to the examination microscopy of trending microslides rhinocytogram up to 6 months. In the group where the injection was carried out in operation, amount of neutrophils was 13%, and in the control group it was 33%. Fusion cell therapy decreased the cytogram. In the control group of circulatory process, in the main group, the severity of inflammation infiltration was characteristic by weak or moderate degree. Symptomatic activity of the inflammatory process was absent in the main group. Preliminary analysis of histological preparation of the sample of the mucous membrane of the nasal cavity indicates a decrease in the degree and activity of the inflammatory process in the mucous membrane of the nasal cavity in patient during cell therapy. The good efficacy of cell therapy allows to recommend it in addition to the standard treatment of chronic rhinosinusitis with nasal polyp during surgery due to the confirmation of effectiveness based on improvement of nasal and sense of smell, decrease in intensity or amount of colored discharge from the nasal cavity after 6 months of observation, the best endoscopic picture of the nasal cavity according to the Kennedy score due to the reduction of discharge, edema, and polyps after 6 months of observation, the decrease in the amount of discharge is greater in the early postoperative period, reduction of inflammation according to observation microscopy of cellular composition of nasal discharge and a cytogram after 6 months of observation, reduction of inflammation according to histological research within 3 months. Thank you for your attention.
I am Hanan Dawood, one of the plastic surgeons in Munawar University Hospital, Egypt. I'm going to present our work about the outcomes of paramedian forehead flap for reconstruction of large nasal defects. So the aim of work, this is a case series study to evaluate outcomes of paramedian forehead flap in reconstruction of large nasal defects, both aesthetics and functional outcomes. This study describes forehead flap technique for reconstruction of large nasal defects more than 2 centimeters after excision of a neoplasm. Background: nasal reconstruction is challenging because of the complex triphasic structure of the nose, 3-dimensional structure. The different components of skin, framework of bone and cartilage, and mucosal lining, as well as the variation of thickness and color of the nose makes it challenging. Subunit principle in nasal reconstruction. Nose is composed of 9.
Hello, Dr. Hanan. Sorry for interrupting you.
No problem.
Please reduce the picture-in-picture size in Zoom, doctor. Your slides are not fully visible. Your video is larger than the slide. Please reduce the size of PIP.
I'm not aware how to do that. You resize.
Not picture-in-picture size. Yes,
Yeah.
now it's fine. Now it's fine.
Thank you.
Okay, doctor, you shall present.
Sorry.
Okay.
Okay. So subunit principle in nasal reconstruction. The nose is composed of nine subunits: dorsum, side wall, nasal tip, ala, soft triangles, and columella. It's critical to consider aesthetic subunits of the nose when planning the reconstruction, as an optimal technique will allow for scar placement at the borders of subunits, and we'll have one type of skin in a subunit. This means if I have a defect that make me remove half of the side wall, it's better to remove all the side wall covering and reconstruct it with a single flap. Forehead flap, it's the golden standard for nasal soft tissue reconstruction, as well as lining sometimes. Because of its robust body pedicle, it's based on the supratracheal artery, which is 1.7 centimeter to 2.2 centimeter from the midline. It gives us a large amount of tissue to reconstruct almost any defect. Lining defects can also be addressed simply and reliably with a folded forehead flap. It has advantages of texture and color match, allows direct closure of the donor site with subtle scar. However, it's a two-stage procedure. Sometimes it's a three-stage procedure in case of expanded paramedian forehead flap. Principles of forehead flap in nasal reconstruction. It's important to maintain an axial pattern, utilizing the pedicle ipsilateral to the defect, extending the flap to right angle with caution, with extra length if extra length is needed, using a narrow pedicle and early subperiosteal dissection or the guiding. Patient and method. Patients who had large nasal defects received surgical treatment in the form of either expanded paramedian forehead flap, Group A, 5 patients, or non-expanded paramedian forehead flap for Group B, 9 patients. Demographic data, nasal defect characteristics, post-operative complications, infection, wound dehiscence, flap necrosis, as well as comparison between two groups of patients, doctor and patient satisfaction were all recorded. Surgical technique. We'll first start with flap design and preoperative marking, making sure that we must include the supratracheal artery, which is a blood supply for the pedicle for the flap. And this marking to mark for us the levels of flap undermining or elevation. So in the upper third, we only harvest the skin in a subcutaneous plane. In the middle third, we allow to harvest also the muscle in submuscular plane. And in the lower third, it's so important to be sharp dissection was done in subperiosteal level to make sure that we include the pedicle. The flap was sutured in one layer to the recipient site, and the donor site was closed directly after undermining of both sides. Pedicle division in a second stage under local anesthesia after 3 to 4 weeks from flap elevation and setting. So we divide the pedicle and reset the flap for the final stage. Expanded forehead flap is another modality. When we have short forehead or a small donor site or a young patient, the expander should be inserted in a pocket between the preosteum and the fascia frontalis, again to protect our pedicle. After that, after complete healing, we start injection of the expander with saline over 3 to 5 weeks until reaching the optimum desired size for the flap. Folded paramedian or folded forehead flap, it's another modification. The distal part of the flap turned on itself, making a pocket to involve the cartilage graft and for reconstruction of the lining of the nose. Case presentation, case 1. 55 years old male patient with fungating mass, SCC, in the nose and upper lip. Patient underwent excision and reconstruction with folded paramedian forehead flap for nasal defect, as well as reconstruction of the cartilage with costal graft, and we reconstructed the lip defect with nasolabial flap. And this is the final picture after about 1 year. The subtle paramedian forehead flap scar, and this is the final result. Case 2, 60 years old female patient, diabetic with rodent ulcer, BCC on the left ala and sidewall. Patient underwent excision with reconstruction with paramedian forehead flap, 3 levels as marked, and ipsilateral mucobrochondrial hinge flap for lining reconstruction, and the structure support with spreader graft, upper lateral cartilage, and alar patent graft. This is the final results after 9 months. Case 3, a boy 5 years old with hemangioma involving the tib, ale, dorsum, and side walls, extensive defect after removal. Patient underwent forehead expander insertion, then excision of the hemangioma and reconstruction with expanded paramedian forehead flap. Results. The overall results were satisfactory regarding function and appearance, without major complications according to patient and doctor satisfaction. Wound dehiscence occurred in one patient, 7.14%, and healed with conservative treatment. Another patient in group 2 was complicated with infection at the site of the expander port and was treated with antibiotic. Conclusion. Forehead flap continues to be one of the best options for closure of surgical defects of the nose larger than 3 centimeters. Adequate knowledge and careful application of the technique and its modifications allow excellent results to be obtained with few complications.
As my study validity and reliability of the Skarzynski Tinnitus scale in Turkish. Yes, we can follow. In the study, the validity is the Skarzynski Tinnitus scale were investigated. We want to make a version of Turkish. Next, we can go. Tinnitus is defined as the perception of the sound without any external acoustic stimulus and a highly subjective complicate. Making is the new treatment opportunities difficult for this. There is a need for standardized methods of determining the effects of tinnitus on the patient's life, social activities, and physical, mental health, and the evaluate treatment outcomes. Given the diverse impacts of tinnitus, questionnaires or scales should be evaluated in a multidimensional way. Over the years, many tests, questionnaires, and scales have been developed for tinnitus patients. Next, we can. This inventory, actually, we wanted to contact as many languages, including Turkish, for the tinnitus. As the handicap inventory, we first looked for this is the PTHSI in Turkey, which is the one most of the widely used scales in Turkey. This PTHSI evaluates the emotional, catastrophic, and functional effects. And we used for the opposite or the nearest things in this RSPS. So we look to each other. We can go next. Next page, we can, yeah. Our studies contacted the Department of Ege University Faculty of Medicine in 2019. We have 143 people for tinnitus. They have tinnitus age over 18, and they have normal otoscopic findings. Was included. They have apparel from Ege University. Next page. We personal information. We collected the demographic data. We make the per tone audiometry, and we make their the Skarzynski Tinnitus scale and another scales for to looking to each other. Next page. tinnitus, THI have the 25 question, and we have the SPS have the 14 questions, and then we Turkish translation. We need this, and we make a translation for multi steps because of we need to safety for this. Next page. We can go next page. Yeah, thank you. And we have some analysis, and we use the SPSS for this, of course. And we have the construct validity for explanatory factor analysis, assess the sample size, suitability, and use Vermax rotation. Next page. And another analysis is the confirmatory factor analysis. We fit in this such the chi-square important one that RMCA and SRMR, GFI and CFI is so important for this because of this to show the how is the going, is the good for or not. And, convergence and discriminant validity is the PTHSI and SPS versus modulation applied with Superman's error test, and we use this analysis tool. And for the reliability inter-item consists of analysis using Cronbach's alpha is the important one. Another thing for these studies, so we use this and test and for this ICC and McNamara Walker statistics for this study. Yeah, this is the data for demographic data. We can go which the family may married or not. As the actually it is not affected for our study. We search this, it is affected or not. So we yeah, we can talking about the results, but yes, we didn't see any positive things. Yeah, next page. We can go on. Yeah, okay. Results. Yeah, we set this 143 voters, and they are 18 and 84 years age, and we have data for demographic characteristics and tone audiology, and of course our scales. Next page. Yeah, the access construct validity confirmatory factor, we look at the CFA for this, and then I said before with the another in case in the case we are looking for this, and with exposure factor analysis, if EFI is the so important another thing, new factor structure for the Turkish SDS, the analysis related to the 3 factors stretch, and the factors were psychology, functional, and coping with item loading supporting the structure. Next page. Our principal access method we used Vermax rotation confirming the 3 factor structure is the Cochlear Mayer Olkin. Is the we test this result in case subject sample size, and it is the support this our model is the 0.33 and 0.81. And our audiometry results right here, average hearing right ear is the 26 decibel, and left ear is 28 decibel. Next ear, next page. We can go next, yeah, okay. Or yeah, we had some analysis, and factor analysis is the FPA we said before, is showing good fit inside our study. So it's so much support. Item 1 was resistant to a different factor due to its emotional context. Convergence validity is the PTHSI scale was used to access the cross-sectional validity of the SPAs. There was a significant positive correlation between the two scales. Yes, next page. International consistency item total correlations indicated good, and it's the mostly about the all points for the internal consistency. It's the correct fact alpha we said before, right? And it's the so very much higher and support the original SPS is the 0.86 and 0.88. And test retest is the again in the support our as the Turkish SDS is the we can say it's the all 0.70. We can say it's the so much higher point. Next page. And you can see again this are our results. We can see another page. Again, our results, you can see are the important G secures another and the exploratory factory and confirmatory factory is the so very good available fit. It's so much. Just one is the incomplete is GFI. Next page. Yes, it's we can see that again. It's the between skirts we can see. Next page, please. Yes, it is the another important figure. We can use all of these studies if we have to make a validity and reliability scale for scale. Yes, we have to do this. It's the show another emotions scale. Next page we can see. Yes, we can see next page. Yes, we can see is the cumulative is so higher, 40 and 40, 90, 49 and 58, which is the same part of the 31. But another thing is that so much is the again okay. Yeah, we can see another page. Yes, it's the characteristics of the for people is the affected or not, and another things is the if they have the tinnitus is how is the coming, is the bilateral or one lateral head, or we can see is the personality or they have a sound variability, yes or no. Again, and the last one, the patient perspection in of the tinnitus is the visible or is the like a warranty or others. Yeah, we write it's just the data is not affected to our scale. We can say that is yes, it's the data, but it's not affected scales for a THI or STS. Yeah, next page, please. And again, we said before demographic characters is like this. You can see how is this the education, sex, marital status, or another thing, but they are not affected to our statistics. We can go next page. This study is the SPS for Turkish. In Otolaryngology, the original three-dimensional factor structure of the scale was tested using confirmatory factor for CFA. But the model did not meet goodness of the fit character. Just after translated the scale into Turkish exploratory factor analysis, we used the three factors structure with the Turkish version. And two items show the difference from the original factor structure. This is the just item 40, but is the another is the not problem, and we said we can escape this. We can use it. Next page, please. PTHSI scale showing the significant positive correlation between the SPS scores. It's a good thing for us, but just the item total correlations and test retest intra-class correction, confidence, internal consistency, and ICC is high reliability. And the study validity and consistency analysis closely resembles Skarzynski's original study. Democratic good internal consistency and excellent reliability across subscales. We can go next page. Comparison with Skarzynski, how is it going? Actually, Skarzynski's original Polish study, so it's the term of factor analysis results, total variance explained, and ICC scores. While there were variation in mean scores and ICC competence involves, both studies demonstrated good internal consistency and reliability, supporting each other's findings. Next page. SDS, Turkish SDS demonstrates reliability and usability among all the adults with tinnitus. We can say it's the practical for clinicals or in the hospitals. It's the so comfort. It's quick explanation and easy make it availability in clinic practice. And but we can say original factor stretch of the scale could not be validated, and one of them in the Turkish version. So we didn't say we can say you don't use the item, but another items is so reliability for using in hospitals or health clinics. Yes, we can go on next page. Yeah, this is my reference, and yeah, that's all. Thank you.
Dear Ms. Marcolino and dear audience, thank you very much that we got the opportunity for surgical data to take part in your World Congress. And but actually about 50% of our patients show up with complaints of the upper respiratory system. So, but this is always not really well known. And as a little episode, we had a patient who got 7 sinusitis operations before reflux was taken into consideration for the cause of these complaints. So today I would like to make you or get you even excited for reflux, and I will show you very unique and interesting data about, according to a new reflux control system which we found. Okay, to keep to make a long story short, we start with the 25 years ago, and I show you the video that maybe how it should be. Yeah, there we are. This is 2003. We did the following operation. This is how we do the reflux operation, and we prepare the area in the abdomen. Here you see the liver, stomach, and the colon area. And if we preparate the area, then we see this in, wait a second. Then we see this in reflux patients. We see this rupture of the diaphragm. Wow. Again, yeah, we see the rupture of the diaphragm. And the normal procedure is that now we do some sutures to narrow these muscles, and then part of the stomach are wrapped around the esophagus to narrow the esophagus, to prohibit reflux. So this is the standard operation all over the world. It's called mesenchymal, and there are some new ideas with magnetic rings, but all these operations have the aim to narrow the esophagus. And what we did some 20 years ago is that when we preparate this, you see that in this, that now the esophagus is actually in the right position, and we only closed this area and we did nothing. Oh, wow, sorry. And we did nothing then, with these videos. Oh, I'm so sorry. I'll keep it going. And we only put the esophagus here into the right position, anatomic right position, and we just closed the muscles here. We developed a special mesh for this, but this is not important for the function. It's only important for the long time stability of this area. It's a three-dimensional mesh, but this is not really important now. This mesh is inserted, and then the muscles are closed. And so with this kind of operation, we have a reconstruction of the normal anatomic situation. There's no wrapping around the esophagus and no narrowing. It's just putting the esophagus to the right position in the whole anatomy context. So then we did this operation in a couple of patients and realized that these patients are really healed immediately after the operation, though we had actually no narrowing, no wrapping, nothing. So we decided to make a big study indeed. It was a 10-year prospective study, and every patient coming to the hospital was, according to the inclusion criteria, included. They all got this operation we just showed to you. And the follow-up of the patients was at T0. This maybe you can remember just now. T0, it's pre-operative, T1 after 1 year, and T5 after 5 years. We had in this study no randomization because all patients coming to us wanted to have this kind of operation, so nobody was willing to have a Nissen or fundoplication, whatever. This is a little bit confusing, but just I want to show these questionnaires. This is T0 before operation, and we differentiated patients when they take at T0 their medication and they don't take. This is so we asked the patient, oh wow, how do you feel if you take your medication? And we ask a lot of questions. It's at least it's more than 2,000 points, but because we did not know what will change after this operation. So we ask for acid reflux, for volume reflux, for pain, for hoarseness, for sore throat, for night attacks of everything what you can imagine, and gastric and chest pain. Okay, and then we ask a lot of things according to diet, sparkling water, fruit juice, coffee. We ask for the doctor's suggestions, what they suggest for the patient, and then the same questions for the patient. Before operation. So before operation, if they do not take their medication, and then this, there we asked these questions, of course, and other ones. And okay, it's just to bring these questionnaires to you. At T1, we ask also all these questions and a couple of questions more as to the quality of life and how do they grade this operation, and the same more or less at T5. Okay, we go to the results. I just wanted to make it short. About 1,351 patients for 10 years. And we had primary hernia and 1,303, and hernia after Nissen procedure. Oh, what is this then? After Nissen procedures, 48. It's maybe okay. Das ist wirklich I'm so sorry. I don't know what's happened here. The recurrence rate is very low, but this is due to the new mesh we developed. The median age, hernia size in the range of 2 to 6 centimeters in the majority. The follow-up rate is, of course, pre-operative, 90–60%. But at T5, please observe this, it's only 14.8%. We had some complications to resurgery. These are mostly due to problems with swallowing. Okay, we had also some mesh complications, 5 patients, and 3 times in the esophagus could be done by endoscopy, and 3 times in the stomach. It didn't make any complaints. Okay, I just go to the results, and this might be interesting. That you see 0, we have this score, and 0 and 1 is always complaints, and 4 is never complaints. And you see that patients with, for instance, hoarseness, they have preoperative grade 2, and with PPI, they have also grade 2. And we know that PPIs often do not help the patients in this for upper respiratory problems. And after operation at T1 and T5, they get rid of all these problems. The same with sore throat. With heartburn, there you see the difference without PPIs. It's 1, with PPIs it's 2, and after operation they don't have heartburn anymore. And then you see, for instance, volume reflux. It's in the scale 2. PPIs, of course, they don't help. So the same with PPIs. But after operation, we don't have volume reflux. We don't have coughs at night. Oh, and everything else, bloating, and so we see this. Just the anatomic reconstruction has an input of a lot of symptoms the patients had before operations. And if we look, for instance, for the problems of diet, you see without medications, cake, chocolate, coffee, and so forth, fruit juice. Wow.
Dazu musst du zuerst dein iPad entsperren.
Fruit juice, red wine, without PPIs, with PPIs, and then after operation. What you also see that PPIs have an effect, but it's really limited, and mostly the patients have to stay to a diet despite they take PPIs. But what is clear that the anatomic reconstruction has a definite effect also on this food uptake, and the BASIC score, the quality of life, is also significant better after operation versus T0 with medication, and here at 1 year and 5 years. Same is the patient rating. The PPI treatment is paid for the patients rated as 5. This is in Germany school notes. It's very bad. You won't come to the next class. And 1 is the best. And you see that the result for the patients and the difference between PPI treatment and the operation is very significant change. So this is the time course of recurrences, also maybe quite important, but this is due to the mesh that we have in the beginning of the years, have a kind of a vulnerable phase, but the longer the operation has happened before, the more, it's very seldom that we get any recurrence. So the point is, what we saw is that this kind of operation apparently has a very good impact on the symptoms of the patient. And so we asked us what happened, because we did not do anything very spectacular. We just looked at the rupture in the diaphragm. Then we, and then we put the esophagus to the right anatomic position, and we just close this diaphragm. So the question is, why is this procedure prone or able to cause so much benefits for the patient? And what is really the closure system in humans? And then we start a MRI analysis of patients before and after the operation. And there we found the following, that we have in this area a kind of clockwork between the heart, the esophagus, and the diaphragm. And it's like a clockwork and an engine in the center of the heart and the center of the body. And it looks like that the esophagus is always in a concave position along the left ventricle of the heart, and the heart is pumping, and with each heartbeat, the esophagus is contracted, and the clearance function of the esophagus and the reflux control is done by this peristaltic pump of the heart with more than 100,000 pumping moves a day. And what you see here is that the diaphragm is very important for this system. So because the crew of the diaphragm, they determine the position of the esophagus. And if you get a diaphragmal hernia or insufficiency, the crura open and the esophagus comes down, and the connection between esophagus and heart fails, and we got reflux because this pump doesn't work adequately. And this you see here, and maybe you have to look a little bit more intensive. You see that this way of pumping you see here in this area, this is the esophagus here, and you see how this area, it seemed to be fat area of the left ventricle, do it again, that here you see this push with each heartbeat, the esophagus get a compression and the content is pushed into the stomach. So this system is important for clearance function, swallowing, as well as reflux control, because with this pumping rate, nothing can come up into the stomach. And this is also, maybe you see this now if you look more, again, look more, and you see this esophagus, and there you see this pumping movement. And this is shown in a contrast enema. Here you see the contrast medium in the esophagus. This whole system is one heartbeat. Here you see the contrast medium and the size and the diameter of the esophagus. It's 12 millimeter. The contrast medium reaches the distal esophagus. Now, after very short second or parts of a second, you see that the wall of the, this is the dotted line, is the 12 millimeter border of the esophagus. And you see now comes the heartbeat. The esophagus wall is compressed now here to 10 millimeter. The heartbeat goes further on, the compression goes to 7 millimeter. And already now the contrast medium is pushed into the stomach. Now the compression goes further and we have a compression to 3 millimeter. And with one heartbeat, the whole contrast medium is already pushed into the stomach. And in this area, the left ventricle loses contact. We have now a compression of the esophagus of 2 millimeter. And here you see already again, the opening of the esophagus for the next swallow and for the next heartbeat and heart compression. So the contrast medium is pushed into the stomach within one heartbeat. And so you can imagine that any kind of reflux has no chance if we have 100,000 heartbeats a day, that if there's something coming up backwards, backwards, then this is here. 1 second, backwards. So this is where we can demonstrate this compression, and it's not a contraction of the esophagus, because what we see, it's not a contraction because it's only the ventral wall of the esophagus which is compressed. It's the dorsal wall is all the time stable. It's all the time stable. Well, this is here, I don't know why. Oh God. So we have the clearance function and reflux control is a matter of the heart and the compression of the esophagus, not of a contraction of the esophagus. And this we see here, and it's also a post-operative picture that you see this area, this the upper part of the stomach, when you see the counter current steadily coming from this compression of the stomach, of the heart on the esophagus. So this continuous counter current is seen here in the upper part, just behind the cardia. So you see that this is reflux control by continuous pumping out of the esophagus. And ja, jetzt haben wir das durch. So this is thematical, what happens in reflux patient. This is the normal situation as you saw. The ascending, it's what we know now, it's about 40 degrees of the esophagus, ascending to the penetration to the diaphragm. And then we have the stable connection between the heart and the esophagus. So this is another, here's the esophagus and the stable diaphragm. If the diaphragm breaks down, it opens and the esophagus falls down. And now we have this situation that the esophagus falls backwards, and now we have a very flat angle and a distance to the heart. And in this situation, we are losing reflux. We are losing control. So I just have to touch something and it moves or whatever. And what we did with this operation in the beginning of our operative studies was, we did not know this, but what we did now, and I show you, is that we just we just elevated, as you show in the video, the esophagus to the normal position, and then we closed the cruva. We did put the esophagus here, and then we got this situation. So in the beginning, we did not know what happened, but now we know how exactly it had to function. So we reconstruct this situation, and this is how the system works. And what we now know is, over here, you see what we did by surgery. I hope it keeps here. This is pre-operative. You see the very flat angle of the esophagus and the distance to the heart. And I may not move anything here. And here is post-operative. You see now the ascending angle of about 40-45 degrees, and we reconnected the esophagus to the heart. So this is the normal anatomic situation, and in the pre and post-op pictures. And this is what we now know, meanwhile, after 20 years, that this system, it's an amazing clockwork system around the heart and connected with the esophagus, with the diaphragm, with the vagal nerve. There's a nervous network between the esophagus and the heart. Patients suffer from extrasystolic palpitations. They have loss of tooth enamels, coughing, hoarseness, laryngitis, otitis media, conjunctivitis, and chronic sinusitis. A lot of complaints, and they are all connected to this clockwork system. And yeah, and it's very important to know that this is the system we have just in our chest, and this very interesting mechanical interaction between the heart, the esophagus, stomach, diaphragm, and so forth. Yes, and this is the take-home message. This guy is from a very nice beer party in Germany, in Bavaria. And he is intact system, apparently. So he does not suffer from reflux. So reflux is the consequence of malposition, not of malfunction. The heart is the central anti-reflux organ in man, and with more than 100,000 beats a day, this ensures reflux protection and clearance function. So we do not have this legendary lower esophageal sphincter. This is neither in histology nor in other examinations. It's proven we don't have any sphincter in this area. It's a dynamic system. So we don't have to narrow the esophagus. We just have to restore the normal anatomy and to bring together these parts in the clockwork. And the weakest point of CODIS, this system we call it, is the hiatus, and hiatal instability causes this slipping of the esophagus. And then we got reflux and all these symptoms all over the body. Restoration of anatomy leads to restoration of function. And we never, since 25 years, we do not any sutures to the esophagus, no sutures to the stomach, and no fundoplication anymore. So this is what we found, and I hope you are you came along with this terrible presentation. But okay, so this is the end. Yeah, thank you very much. And I don't know how it's going on.
Thus, I'm going to present about this primary mucinous carcinoma of the skin. The story really started when I got a skin biopsy from our ENT surgeon. There was some cystic lesion around the ear. So, and the clinical diagnosis was that of some sort of benign cyst. But when he got back my pathology report, he was extremely surprised that the diagnosis was primary mucinous carcinoma of the skin. And he said to me, Mukund, what is exactly this primary mucinous carcinoma of the skin? I was suspecting some benign cystic lesion, and here you are giving me this extremely rare diagnosis. I never heard about this. So can you please explain to me in a little bit detail what exactly it is? So I tried to compile some information, and I thought I will share that information with the group. So what this primary mucinous carcinoma of the skin is an extremely rare skin condition, and it's very important to make its correct diagnosis because vast majority of the mucinous carcinoma of the skin represent metastatic tumors. So primary mucinous carcinoma of the skin, that way is very rare. And because it is rare, it is very easy to miss this diagnosis, and it may be misdiagnosed as some metastatic mucinous carcinoma of the skin. A lot can be said about this neoplasm, but for today's presentation, we'll concentrate on mainly these three features, clinicopathologic features, some differential diagnosis, and management and prognosis of this neoplasm. So what exactly is this primary mucinous carcinoma of the skin, or PMCS? As I told you, it's a rare neoplasm, and it's a neoplasm of the sweat gland origin. And it may be mistaken for more common metastatic carcinoma to the skin. It was first described way back in 1952 by Lennox, and it was later named by Mendoza and Helvey. In fact, they summarized clinical and pathological features based on their observation of 14 cases. So it usually involves head and neck region, eyelid mostly, but areas around the ear can also be affected. And that is exactly how I got this specimen from our ENT surgeon. As I told you, extremely rare, incidence being 1 in 150,000 cutaneous lesions. very wide age range, 31 to 89 years, median being 65 years. There is slight male preponderance in some studies, but not in all. As I told you, head and neck is the most common location, but it can practically occur in any body site, hand, vulva, buccal space, scrotum, skin of breast, you name it. But by and large, head and neck is the most common site. And clinically, it presents usually as some asymptomatic nodule or a cystic lesion, like in our case, or an ulcerated mass, usually 1 to 3 years duration. Now, this is a big list of clinical differential diagnoses. And when I say that, it is only other way of saying that there is no way, there are no characteristic features by which a clinical diagnosis is possible. So clinical diagnosis is absolutely varied. Some absolutely benign conditions like epidermoid cyst to highly malignant adenoid cystic carcinoma, metastatic carcinoma, and so on. And the correct diagnosis comes only after pathologic examination. So this is how typically the tumor presents, like a nodular lesion. This is from our case. And this is the histologic section from this nodular lesion. So let us look at some of the pathologic features. So this is one section of the skin from the lesion, routine H&E stain. Here we can see that epidermis is completely normal. And within the dermis, we are seeing this neoplasm. One thing we can mark here that there is no connection, absolutely no connection between the tumor and the overlying epidermis. And the tumor per se, there are nodules of variable sizes and shapes. And then the second important feature, because of which the name of the tumor comes from, a lot of mucinous stroma. And then some areas we can see this cribriform architecture formation. This is a higher magnification, again showing a cluster of tumor cells showing some sieve-like or cribriform formation and abundant mucinous stroma in this part. Some more pictures from, these are all from our case, and we can make some observations from these pictures. We can see that it is a dermal-based neoplasm. It is a relatively circumscribed, but there is no capsule around it. And then it is mainly in the dermis, but it can extend into the subcutaneous tissue. Mucinous stroma. And that mucin, if you apply a spatial stain for mucin, this is one mucicarmine stain, and all this pinkish material is the mucinous stroma of the neoplasm. This is also one of the nodules, again from the same case. So just to revise those pathologic features, what I showed you, it's a well-circumscribed, unencapsulated dermal nodule, which may extend into subcutaneous or deeper tissues. There is no connection to the overlying epidermis or skin adnexa. And we have already seen this. Tumor is seen as small islands, clusters, tubules. There is a cribriform architecture formation. And one thing to remember, sometimes it may be a mixed carcinoma. By and large, it is pure mucinous carcinoma. And by mixed carcinoma, I mean that there may be a pure mucinous carcinoma component, and in addition, a typical invasive ductal carcinoma-like component. So Kazakov et al. Studied by and large the largest series of consisting of 37 patients, and in their series, mind well, these are all case reports they tried to analyze. So 31 cases were pure mucinous carcinoma. There are 6 cases where mixed carcinoma, invasive ductal carcinoma, and then some mucinous carcinoma component. And in 18% of the cases, 18 out of 37, that is about 50% of the cases, there was an in situ component. Now, this in situ component is very important when it comes to diagnosing this tumor. But unfortunately, it is only seen in 50% of the cases. Remaining 50% of the cases, it is not seen. So it can still be primary mucinous carcinoma of the skin, but it's more challenging. This in situ component is considered as a precursor of primary mucinous carcinoma of the skin. And as I told you, when present, we can be almost certain that we are dealing with a case of primary mucinous carcinoma of the skin, because metastatic mucinous carcinoma of the skin will never show the in situ component. And how that in situ component looks, I will try to show here. So these are all multiple sections of the tumor with using some immunohistochemical marker studies. And these are all clusters of tumor cells. But there is some subtle difference between these different clusters. For example, here, this one cluster of cell, we see a very clear-cut layer. These are all myoepithelial cell. So there is a very clear-cut myoepithelial cell layer. This is one immunohistochemical marker P63, which highlights this. Now, this is another cluster. Again, these are all myoepithelial cells. This is another stain doing exactly the same thing, highlighting the myoepithelial cell. This is smooth muscle myosin heavy chain. So the point I'm trying to make here is that clusters which show myoepithelial cells represent the in situ component. And when in situ component can be demonstrated in a tumor, you can be almost certain that this is a primary mucinous carcinoma of the skin, and you can convincingly rule out metastasis from other sites. Now, just to show you the difference, this cluster looks exactly like other clusters, but only difference, there is no myoepithelial cell layer around it. Similarly, these clusters, they do not have myoepithelial cell layer. So that means this is all those portions represent the invasive component. And sometimes entire tumor may be composed of an invasive component, and there you will have some difficulty when it comes to differential diagnosis. And as I told you, in situ component is seen in only about 50% of the cases. Sometimes these tumors may show neuroendocrine differentiation, and then you call them new endocrine mucin-producing sweat gland carcinomas. This is also considered a precursor of primary mucinous carcinoma of the skin. Our case did not show any neuroendocrine differentiation. Now, is there a role of immunohistochemistry in making this diagnosis? Certainly, there is a role of immunohistochemistry. All these tumors show positivity for pan-cytokeratin markers, AE1, CAM5.2, all these markers. And then there is a variable positivity for gross cystic disease fluid protein, GATA3, androgen receptors. Now, we have to remember one thing, that this GCDFP 15, that is gross cystic disease fluid protein, and GATA3, these are the markers of breast carcinoma. In that sense, breast carcinoma metastasizing to skin will be positive for these markers, and the primary mucinous carcinoma is also positive for these markers. So you can imagine the difficulty in arriving at a correct diagnosis, because you cannot rely on these markers. Tumors showing neuroendocrine differentiation can show positivity for neuroendocrine markers like NSE, synaptophysin, chromogranin. Just to show some positivity for markers, this is pan-cytokeratin, CK7. This, as I was telling you, gross cystic disease fluid protein, GCTFP, mammoglobin, another breast marker. So this primary mucinous carcinoma of the skin mostly shows positivity for these markers. Also, there is a positivity for estrogen receptor, progesterone receptor. So that was about the pathologic features of this neoplasm. Let us change gears and talk about differential diagnosis. So the most important differential diagnosis, metastatic mucinous carcinoma from other sites. It's important to exclude metastatic mucinous carcinoma to the skin before diagnosing primary mucinous carcinoma of the skin. And the two most common neoplasms metastasizing to skin are breast mucinous carcinoma and gastrointestinal mucinous carcinoma. We'll try to see how we can differentiate from these two neoplasms. So, metastatic mucinous carcinoma of the colonic origin. In all such cases, clinico-pathologic correlation is vitally important. So endoscopy comes very handy because endoscopy will show a colonic tumor. Imaging studies are also very important in coming to the specific diagnosis. There are some pathologic features and the pathologist will be able to rule out colonic cancer based on some morphologic features and some immunohistochemical studies. The immunohistochemical profile of colonic carcinoma is quite different from that of primary mucinous carcinoma of the skin. Primary mucinous carcinoma is positive for CA7. It is negative for CK20, whereas colonic cancer is positive for CK20. Also, it shows positivity for CDX2, MUC, and also there is a lot of dirty necrosis. What we mean by dirty necrosis is a lot of karyorrhexis, so a lot of nuclear debris in the necrosis, and it's a very characteristic feature of colonic adenocarcinoma. So colonic carcinoma can be relatively easily ruled out. More challenging is the metastatic mucinous carcinoma of the breast origin, because as I told you, both look morphologically same and they share the immunoprofile. They have similar immunoprofile, and that makes the situation very tricky. And therefore, in this situation, clinical examination becomes even more important. So clinical examination, imaging studies of this breast, they will be helpful in such cases. In our case, clinical examination did not show any evidence of breast tumor. Also, breast imaging studies were all negative. So that is how we ruled out. But if there is an associated breast tumor, it will be really a nightmare to decide if we are dealing with a case of primary mucinous carcinoma of the skin, or whether that skin lesion is actually metastasis from breast mucinous carcinoma. Now, I told you this before, but again, I will like to emphasize that if we are lucky, we might see the in situ component, and then the diagnosis of primary mucinous carcinoma becomes easy. But only problem, absence of in situ component does not exclude primary mucinous carcinoma on the skin. So that was about differential diagnosis. Now let us briefly talk about the treatment. So by and large, surgery is the most important treatment. Excision with a generous margin. Now, question would be, how much margin is good margin? By and large, in most of the studies, they have demonstrated that 1 to 2 centimeter margin is good. And there are less chances of recurrence and metastasis. Most micrographic surgery is the most ideal treatment. It's not possible in every situation, but otherwise this is the most ideal treatment. Also, we have to remember that these tumors are resistant to radiotherapy and chemotherapy. So surgery remains the most important treatment option. Now, it leads to another question. Outcome after surgery. This Kamalpur et al., they tried to review 159 patients. It's by large the largest series they have studied. Because as I told you, these tumors are so rare that most of the cases are reported merely as a case report in the literature. So from this 159 patients, good prognosis, good outcome was characterized by when there were no recurrences or metastases. Poor outcome was characterized by presence of recurrences or metastases. And they concluded that large tumors, those which persisted for longer periods before surgery, and those located on the trunk, they were associated with poor outcomes. Now, fortunately, metastasis rate is very low, about 11%. Now compare it with non-mucinous sweat gland carcinoma, almost 50% metastasized. So that way it is a low-grade neoplasm. These are some people postulate that these are some of the reasons for low rate of metastasis. Nothing sure about it, but like high degree of cellular differentiation, intercellular cohesion, mucin production, relatively avascular neoplasm might be contributing to the low metastatic rate in primary mucinous carcinoma of the skin. But again, these are all only speculations. What about the recurrence? Papalas et al. He studied 14 patients of primary mucinous carcinoma of the eyelid. But I presume this the same principle will apply to other body sites. These patients were treated with Mohs micrographic surgery or under frozen section control, and the patients were followed for about 3 years, 36.5 months to be precise, and there was a recurrence rate of about 7%. Again, we should remember, mortality in these tumors is independent of sex, race, primary site, histologic tumor grade, tumor size, tumor stage, and treatment. And due to scarcity of reported cases, no factors with clear prognostic significance have been identified. And again, these are just speculations, and some people think that diploid DNA content, low percentage of proliferative cells, and absence of P53 and CER2 expression may be associated with indolent course with a low recurrence and metastatic rates. But again, nothing sure about it. So that was in short about this interesting and very rare primary skin neoplasm, primary mucinous carcinoma of the skin. I think that is the last slide.
Assalamualaikum warahmatullahi wabarakatuh. Hello everyone, my name is Asti Kristianti. I would like to present my result study. Let me share my screen. Okay, the title of my study is Comparison of Cochlear Function Before and After Shooting the 105 howitzer cannon based on DPOS examination. And for introduction, acoustic trauma is a condition where a single exposure to intense and loud sound can cause immediate hearing loss. The intensity is about 140 decibel. It can cause damage to the hair cells of the organ of corti in the inner ear, with metabolic or mechanism. The noise intensity of the 105 howitzer cannon is 148.6 decibel, and it can lead acoustic trauma. The OAE examination or otoacoustic emission serve to provide information about the integrity of the other hair cells in the cochlea. We choose distortion product otoacoustic emission to examine the cochlear function before and after howitzer cannon training. Field Artillery Education Center or Pusat Pendidikan Artileri Medan, we call it Pusdik Armet, perform 105 howitzer cannon shooting practice as the curriculum for military students. This research aimed to compare the cochlear function before and after 105 howitzer cannon shooting practice carried out by Pusdik Armet students based on DPOIS examination. This research is an observational analytic study with a cross-sectional approach. The subjects of this research were students from the Pusdik Armet, with inclusion criteria Pusdik Armet students who took part in the DPOIA examination before and after firing the 105 howitzer cannon, with exclusion criteria Pusdik Armet students who only had one DPOIS examination result, and Pusdik Armet students who had abnormal otoscopic examination results. This research has received ethical clearance from the Research and Research Ethics Committee of Dustira Military Hospital. A total of 100 data from Pusdik Armet students' cochlear function examination were obtained on the 20th and 27th of May 2023, with all male, 100% male, with age range 18 to 22 years old. The description of DPOIA result before 105 howitzer shooting practice, the students had 90% normal cochlear function before they had shooting practice, and 10% of students had abnormal cochlear function. DPOIA result after 105 howitzer shooting practice, they had 76% of normal cochlear function and 24% abnormal cochlear function. Hearing loss can be caused by congenital abnormalities, infection, neoplasm, trauma, and for this research is noise, and then cerumen obstruction, poison body in the external auditory canal, and medication use. Other risk factors that interact with noise include age, gender, individual vulnerability, history of hypertension, family history of hearing loss, hearing protector use, personal listening devices use, smoking, and ototoxic drugs use. The noise frequency of the 105 howitzer cannon is 148.6 decibel. This can cause acoustic trauma, which is hearing loss due to short period of high frequency noise exposure. Sasongo mentioned in 215 that the incidence of acoustic trauma at the acoustic arm at Cimahi was found in Canon Sutter at 23.5%. The pre-DPOA and post-DPOA data were not normally distributed with p-value less than 0.05. So we had a significant differences between pre-DPOA and post-DPOA. That post-DPOA had worse cochlear function, abnormal cochlear function. And the conclusion for this study is there is a difference in cochlear function before and after the Howitzer 105 Canon soothing practice, and the cochlear function was found to be worse after soothing practice. Okay, that's all my presentation. Thank you so much for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Good day, everyone. I am Dr. Claudette Gloria Plumo, an Otorhinolaryngology head and neck surgery resident from Quezon City General Hospital in the Philippines. I will be presenting our paper entitled The Effects of E-Cigarette Vaping on Voice Quality and Vocal Cords Among Patients in a Tertiary Hospital in Quezon City. Studies have shown that smoking has negative effects on the vocal cords. It can induce several diseases, including vocal polyps, vocal carcinomas, and chronic inflammation. Moreover, smoking has a significant impact on laryngeal structures, phonatory physiology, aberrant vocal fold edge, texture, edema, erythema, mucosal cover, face symmetry, and flexibility or rigidity. In recent years, electronic cigarettes or e-cigarettes and vaping have acquired popularity as an alternative to smoking, especially in those individuals quitting smoking. It is perceived as a safer alternative to cigarettes. E-cigarettes are electronic devices consisting essentially of a cartridge containing e-liquid and a heating element or atomizer required to heat the e-liquid to produce a vapor that can be inhaled. When e-cigarettes are heated in the mouth, a vaporized liquid is produced that is inhaled and travels through the pharynx, larynx or vocal cords, and into the lungs. E-cigarettes simulate the physical and sensory experience of smoking. E-cigarettes were invented in China in 2003 and contain nicotine ranging from 0 to 34 milligrams per milliliters, propylene glycol, glycerol, distilled water, and flavorings. The majority of reported e-cigarette adverse effects involve the mouth, esophagus, and respiratory systems. It was found that acute e-cigarette exposure may compromise lung function and that e-cigarettes have an immediate adverse physiologic effect after short-term use, comparable to effects caused by cigarette smoking. Another study discovered that e-cigarette aerosols induce oxidative stress and inflammatory response in human lung epithelial cells. A study on the effects of the mist found that acute and chronic exposure led to dry cough and pharynx. It was also discovered that e-liquids are cytotoxic to the oropharynx. The oropharyngeal epithelium is comparable to laryngeal tissue, allowing for the possibility of a similar effect on the laryngeal structures. Furthermore, inhaling the heated vapors from e-cigarettes causes mucosal burn to the epithelium and damage to the rhinky space, manifesting as erythema and ulcerative lesions on the vocal folds. These inflammatory reactions and ulcerations resulted in biochemical changes to the vocal fold properties, which cause dysphonia. Here's the general objective of the study. And here are the specific objectives of the study. This is a cross-sectional analytical study done at Quezon City General Hospital. 98 patients aged 19 years old and above with no previously known laryngeal illness who use e-cigarettes completed the Filipino Voice Handicap Index or VHI questionnaire, laryngoscopic evaluation, and Garbas evaluation were recruited in the study. The Filipino VHI is a reliable subjective tool for identifying vocal dysfunction by measuring psychosocial handicap through a validated questionnaire. Patients answer the questions with their personal perception of their dysphonia. The questionnaire contains 30 statements of reactions to and experiences on voice disorder. The functional subscale consists of 10 statements that describe the impact of a person's voice disorder on his or her daily activities. The emotional subscale contains 10 statements that describe how the patient feels about the voice disorder, while the physical subscale consists of 10 statements that describe self-perceptions of physical manifestations of dysphonia, such as laryngeal discomfort and the voice pitch. A 5-point Likert scale is used representing the answers for each statement: 0 or never, 1 or almost never, 2 or sometimes, 3 or almost always, and 4 or always. The mean for each subscale is computed, and the severity of the voice handicap is directly proportional to the mean subscale score and the total VHI score. The Garba scale has 5 parameters that assesses overall dysphonia: grade, roughness, breathiness, asthenia, and strain, and has 4 categories: normal or 0, slight or 1, moderate or 2, and severe or 3. Grade is the degree of hoarseness of the voice. Roughness is the impression of irregularity of the vibration of the vocal folds. Breathiness is the degree to which air escaping between the vocal folds can be heard by the examiner. Asthenia is the degree of weakness heard in the voice, and strain is the extent to which strain or hyperfunctional use of phonation is heard. Erythema, edema or swelling, vascularity, and mucus in the vocal folds and laryngeal structures were graded using the non-vibratory observations rating form, a rating system used by Sample in 2019, adapted from Hiran and Bless in 1993. The ratings are 0 or within normal limits, 1 or mild, 2 or moderate, and 3 or severe. The research proceeded as follows. Patients signed an informed consent prior to inclusion in the study. Baseline demographic and clinical data were collected to include age, gender, comorbidities, use of cigarettes, frequency and duration of e-cigarette use, type of e-cigarette nicotine system used, and nicotine content level. The sample population was divided into 2 groups, current and past e-cigarette users, for comparison. During physical examination with emphasis on vocal cords and voice were done. Patients answered the Filipino VHI questionnaire, and the scores were recorded in a database. Afterwards, they were asked to read an excerpt from a summary of Ang Ibong Adarna, and the recordings were gathered. Videolaryngoscopy was performed to assess the appearance of the larynx and recorded. Data gathered was entered into a database. The voice and laryngoscopy recordings were evaluated by a laryngologist using the Garba scale and the non-vibratory observations rating form respectively. Statistical analysis was then conducted. Out of 105 participants, a total of 98 were included. The 7 participants were excluded because of incomplete data. The ages of the participants range from 19 to 59 years old, with a mean age of 30.6 years old, and the majority were males. Out of 98 participants, 65.3% and 34.7% were current and past e-cigarette users, respectively. 29.6% had abnormal laryngeal findings. The comorbid conditions were hypertension, asthma, and diabetes mellitus. Asthma and concurrent smoking were significantly higher among those with abnormal laryngeal findings than those without. The number of years vaping ranged from 0.5 to 7 years. The mean number of years vaping was 2.3 among those with laryngeal findings and 2.4 among those without. The mean number of pods per week was 1.6 among those with laryngeal findings and 1.8 among those without. The mean number of drops used per day was 0.8 among those with laryngeal findings and the same for those without. Finally, the mean nicotine content level was 3.6% among those with laryngeal findings and 4% among those without. Based on the non-vibratory observations rating scale, the total scores of each participant ranged from 4 to 16. The mean scores were 7.7 and 6.9 among current and past e-cigarette users, respectively. Out of 98 participants, laryngoscopic findings are as follows. Mild vocal fold mucus had the highest frequency and was found in 72.5%. The prevalence of abnormal laryngeal findings among those with current e-cigarette use did not differ significantly with past users. Years vaping, pods used per week, drops used per day, and nicotine content level were not significantly associated with abnormal laryngeal findings. Based on the Garba scale, the total scores of each participant range from 0 to 4. The mean scores were 1.2 and 1.3 among current and past e-cigarette users, respectively. Out of 98 participants, the Garba scores are as follows. Mild roughness had the highest frequency and was found in 80.6%. With regards to the mean Garba scale scores, there was no significant difference between current and past e-cigarette users. Concurrent smoking was significantly associated with higher Garba scores. Years vaping, pods used per week, drops used per day, and nicotine content level were not significantly associated with Garba scores. For the VHI scores, the total scores range from 0 to 26. The mean total VHI scores were 6.5 and 5.5 for current and past e-cigarette users, respectively. There was no significant difference in the mean VHI scores between current and past e-cigarette users. Years vaping, pods used per week, drops used per day, and nicotine content level were not significantly associated with VHI scores. This study showed that around 30% had abnormal laryngeal findings. This was higher among current e-cigarette users than past users, but the difference was not significant. It was found that e-cigarette use had no significant association to voice quality and changes in laryngeal structure. This agrees with the local study that found no statistical difference between the Filipino VHI scores of e-cigarette users and smokers. Concurrent cigarette smoking was a significant predictor of abnormal endoscopic findings and voice quality. Because increased secretion impacts the acoustic properties of the voice in the smoking group, the acoustic qualities of the voice in the e-cigarette group may be less influenced than in the conventional cigarette group. Consequently, secretion is found to be lower in e-cigarette users than in traditional cigarette users. This may also be because e-cigarettes have more vapor and less toxins than traditional cigarettes. However, this does not imply that e-cigarettes have no absolute potentially harmful consequences. One study revealed that although there was no significant correlation between the use of e-cigarettes and abnormal acoustic measurements, there was a significant correlation with other measures, including vocal fold varices, edema, and abnormal face symmetry. Other studies also showed that vaping had toxic effects, especially on the vocal fold mucosal health and airway protection. Moreover, it caused epithelial alterations that might result in thickening of the basement membrane, hyperkeratinization, and localized basal cell hyperplasia. Varying results of the current and previous studies may indicate that further research is still needed to fully explore the association of e-cigarette vaping on voice quality and laryngeal structure changes. Since e-cigarette use is a novel and popular way to quit smoking, more thorough research on e-cigarettes and their effects on voice is necessary. Limitations still exist in the study. One limitation is the lack of data on the e-cigarette variations, such as e-cigarette device or flavoring compound used by the participants, which may have additional effects on the result. Additionally, the data gathered was from a single hospital, which may indirectly be affected by several factors, such as socio-demographic similarities. Thus, it might not reflect the population in general. More so, the true problem of the vocal cords or laryngeal damage may have been underestimated, since some patients may not have sought medical evaluation. It would be highly valuable to conduct multi-center trials, including both hospitals and communities, to assess more detailed outcomes. It is recommended to compare e-cigarette users to non-e-cigarette users to better show its effects on voice quality in the vocal cords, and to include current e-cigarette users only. Video stroboscopy may also be done to provide more detailed and accurate assessment of the voice and vocal cord movement. Despite limitations, this study can still contribute to understanding the effects of e-cigarette vaping. Thank you.